This is Jay Callahan with another video mini lecture. Today's video is part 2 of my 3-part series about actually conducting crisis intervention sessions. As you recall, the first of these 3 videos is about the initial phone call and about process issues that apply to, in particular, the first session, but really across all sessions. Today we're going to talk about the first session and the assessment of crisis. So after you've taken care of whatever bureaucratic paperwork or intake function that you need to take care of, in the actual beginning of the interview, the first thing that really happens is the client tells their story. Almost everybody who comes in for crisis intervention because of a stressful event wants to tell their story. And that should be the first thing that that's on your agenda, as I said, after the check-in procedure is done. So basically, you want to try to do whatever you can, and we talked about that with process issues, with empathy, with active listening, with trying to put the client at ease as best you can, that you can establish a safe environment, and then get out of the way for them to be able to tell their story. And their story is basically a chronology of what's happened to them recently, leading up to and including the stressful event. One aspect to consider is whether there was a hazardous situation before the stressful event. A hazardous situation means that prior to the precipitating event, the stressful event, the individual was already struggling. They were already stressed out by other factors in their life. They were already just barely able to not be knocked off their homeostatic balance. So things were fragile, and then the stressful event came along. So it's good to know if the client was in that kind of fragile state, which in the literature is called a hazardous situation. Obviously, you need to hear about what was the stressful event, and why in particular was that event the one that was the last straw that led their coping mechanisms to be overwhelmed, led them to not be able to function anymore at their normal level of functioning, things like that. And why now? Would this event have had the same impact any time in their life, or is there something about the timing right now? And the other important thing to talk about in the initial telling of the story is that occasionally it's too overwhelming and the client doesn't really feel comfortable telling the whole story at one time. So the idea here is certainly don't push someone, don't pressure someone to tell more than they're comfortable telling at the time. You can do it in chunks over the first few sessions. Okay, the next important aspect in this first session is to confirm that the client actually is in crisis. And one of the aspects of crisis that I don't think I brought up earlier, but it's an important one, is that a crisis is by definition different than the person's baseline. It's different than their normal level of functioning. Obviously it's lower than their normal level of functioning, but it's qualitatively different as well. So just because someone comes in and they have an intense level of emotionality and upheaval in their life doesn't necessarily mean they're in a crisis. I mean, it may look that way at first, and you may think, wow, if I had all this stuff going on in my life, I'd certainly be in crisis. But it's not necessarily so. So in order to be sure about that, you really need to compare how they're doing now with how they were doing before the stressful event happened, their previous level of functioning, occupationally, interpersonally, just an overall picture of how they were doing and what sort of level of stability they had before this stressful event. And if it turns out that they had a chaotic series of negative events happening even before this most recent stressful event, then in other words, their previous functioning is the same as now, that right now it's not different than their baseline, then it's not a crisis. And as I put on the slide, a chronically unstable and chaotic lifestyle is not a crisis. And of course, you don't do crisis intervention if it's not a crisis. Some clients who may fit this description may have borderline personality disorder, or they may have other personality disorders, or they may have alcohol or drug abuse. And of course, remember, for people who have had multiple traumatic events, typically in the past, crisis intervention is also inappropriate for them. Crisis intervention is only appropriate for type 1 trauma. We talked about that before. Another important aspect to spend a little time on in this first session is to find out about previous similar experiences. And that would be triggered by asking, did anything like this ever happen to you before, or have you ever felt like this before? And you can get a picture then sometimes if a person had a similar crisis in the past, it kind of give you a picture of what might happen this time, or the kind of event that tended to lead them into a crisis before might be similar to what's going on now. A major part of the first session is to assess the client's coping, support, and meaning. So we're going to ask about, and we're going to listen for, what coping mechanisms have they used, and we're not going to comment about it, but we're going to listen about which ones seem to be adaptive, which ones seem to be maladaptive. And also, another part of coping is how well can they handle the strong feelings that gets gotten stirred up by the event and by their subsequent state of crisis. Secondly, we're going to try to assess their support system, listen for who they've gone to, what people they've contacted, and also, to an extent, what is their support system, and are they using it or not. I also spoke earlier about the idea of homecoming, which is the initial reaction of significant others after a traumatic event. And it's important to listen for that too, especially the idea that some of the significant others may have had a negative or judgmental response. And then thirdly, we're going to listen for the meaning of the event. And often the event represents some sort of loss in an area of the person's life that's important to them. Okay, now all through this, we're going to listen, we're going to assess, we're going to ask questions, but this is an assessment phase in the first session, so we're not going to try to do any kind of intervention at this point. That comes later. Another important aspect of this first session is to assess whether there are any mental health emergencies. And again, that means threat of physical harm to someone, suicide, potential violence, and a situation of defenseless victims. Okay, so I'm going to go into it a little more now than I did when we talked about the initial phone call, but this is part of what we'll talk a lot more about in the second half of the course when we do talk about mental health emergencies. But in this first session of what we think is crisis intervention, it's still important to clarify whether there are any mental health emergencies. So in the suicide area, you might ask, have you had thoughts of suicide lately? Or you might say, since this happened, have you had thoughts about taking your own life? Or you might say, have these serious difficulties made you think about killing yourself? Okay, any of these, I think, phrases are okay, and you can try and tie it to the nature of the story. It's important that you demonstrate that you can take it, that you're not afraid of talking about the topic of suicide. And if you say something like, well, you're not thinking about doing something foolish, are you? Right? If you beat around the bush like that and avoid any of the strong words, that will simply show the client that you yourself can't handle the idea of suicide, not be able to talk about it. So you need to be straightforward. You need to not use euphemisms. Secondly, you're going to ask about thoughts of violence, not homicide. One of the things that always kind of annoys me is that so often mental health professionals talk about whether a client has thoughts of suicide or homicide. And I'm like, well, if he's just going to really beat up his neighbor, we're not concerned about that. He's going to beat up his girlfriend, we're not concerned about that because it's not homicide. This really makes no sense. The catchphrase that we should be concerned about is suicide and violence, not suicide and homicide. So here it's really helpful if you can phrase your questions to match the content of the story. So when there's a story that has a bad guy in it or someone who has harmed or wronged your client, then it can flow very easily for you to say, have you had thoughts about getting back at him for that? Or have you thought about getting revenge for that? Have you thought about hurting the guy? Have you had violent thoughts about this guy? Right? So you can fit your question to the story. And then finally, is your client a defenseless victim that you need, and we would need to try to ensure their safety? So are you in danger? And if a client says yes to any of these, then that's the definition of a mental health emergency. It doesn't matter how it comes out. If they say, well, yeah, I have been thinking about suicide, that makes it a mental health emergency right now, and that tells us that we need to do an intervention focused on that, the emergency intervention, of which the important part is the risk assessment. So it doesn't matter how it comes out. It doesn't matter if it turns out that the person's risk for suicide is low, and therefore we can go back and continue with our crisis intervention. The point is, when you first hear that there's some possibility of suicide, violence, or a defenseless victim, that makes it a mental health emergency, and that means you shift gears and go after that. But if not, then we're just going to continue with crisis intervention. Okay? Our next step also is to assess the symptoms of traumatic stress. So I'm not going to spend a lot of time on this because we've talked about this already. And once again, I hope that you're able to remember off the top of your head the 5 symptom clusters of traumatic stress. Now, obviously, you're only going to ask about these if the stressful event was traumatic, not if it was normative. And so the clusters of symptoms of traumatic stress: intrusive symptoms, negative mood and lack of positive emotions, dissociative symptoms, purposeful avoidance, and physiological arousal. You'll recall that we talked about these already. What else do we do? A few other things in the first session. We're going to try and come up with a diagnostic assessment, and whatever it is, it is. So if a client has had a stressful event and now they're mostly depressed with a lot of the vegetative signs of depression, like anhedonia, difficulty concentrating or focusing, difficulty making small everyday decisions, loss of appetite, these kind of things, then the diagnosis would be major depression. It is what it is. But so often in cases of crisis intervention, if the stressor is traumatic, then the diagnosis is frequently going to be acute stress disorder. And if the stressor is normative, then typically it's going to be adjustment disorder. Another thing to keep in mind is mandatory reporting, right? Have you heard any evidence here of possible child abuse or neglect? Any possible evidence of elder abuse, neglect, or exploitation? And also, is there any threats of violence that the client is making that you need to warn a third party against or about? Okay, so mandatory reporting means if you learn about some of these things, you either know or should have known about some of these things, and it comes out later that you did not make the appropriate report, you can be held civilly liable and criminally liable. Now, admittedly, it doesn't happen very often. The punishment for not reporting doesn't happen very often, but it does happen occasionally. The idea about duty to warn a third party is not actually mandatory reporting, but it's based on case law, and we'll be talking more about that later. Another important point to keep in mind is that when the stressful event involves the death of someone close to the client, which we would call traumatic death, then it's important that the client be given an opportunity to deal with the traumatic event and the traumatic stress symptoms first, and only after that the grief symptoms. So it's traumatic stress symptoms first, grief reaction second. A number of studies have shown that it doesn't work very well to do it the other way around. You want to help the client not blame themselves and not blame others. That takes us down blind alleys that don't help. And then you're going to propose, and I've written on the slide, propose crisis intervention. I don't necessarily use that term with people, but basically you're going to propose that you meet probably twice a week over the next few weeks with this client, that maybe a half a dozen sessions altogether, but whatever the client needs, but you're guessing it might be up to a half a dozen, and that they can also reach you by phone in between sessions if necessary. So first, I want to say about that in doing that, often it's helpful to do it with a hopeful tone, like, and if we meet maybe twice a week for the next few weeks, I'm really confident that you'll get back to your normal self after a few weeks. And then secondly, the idea about phone calls in between sessions. This is therapy. You're their therapist, and they may need to talk about issues that have come up in the therapy. This is not an emergency backup for an agency where you're just available so if in case of a mental health emergency, suicide or violence. And actually, even increasingly now, agencies and organizations aren't even doing that. They're just basically putting a message on their voice message that basically says either call 911 or go to your local hospital emergency room. Now, I think that's kind of a cop-out in some ways, but that's increasingly what agencies and organizations are doing. But this is different. This is your client, and they may have some things that they need to talk about between sessions. Now, in doing this, I have never had this be abused. Now, I have had some other situations when I worked in the ER where borderline clients got a hold of my phone number, and did call me up inappropriately. But in crisis intervention, first of all, people rarely call between sessions. And second of all, I have not had people abuse that. So finally, in this whole process, we're trying to convey hope. And here's another quote from Doug Puryear. You're attempting to convey by your entire approach, your attitude, that the client is a capable, decent person who has been temporarily overwhelmed by extreme stresses, and who will use your help to cope with these stresses and get back on track. Right? So your whole approach is to convey that kind of hope. All right, so that's the end of this video number 2 of the 3-session series about actually conducting crisis intervention. In the third video coming up next, we'll be talking about what to do in the second, third, and subsequent sessions. All right, so I'll see you then.